Good afternoon. I am Crystal Nicole Donovan, and I'm going to talk to you about Sanism. Many individuals have heard about ableism, maybe experienced ableism, but as not as many people are familiar with its counterpart, Sanism. And it's come up in conversation a few different times, so I thought we would spend a few minutes talking about it. Our objectives this afternoon are pretty straightforward. Participants will be able to identify Sanism, define disability, and identify action steps to engage in equitable and affirming care. And I was thinking, we were just talking about the schedule for the rest of the year. And before we know it, people are going to be quoting uh, Dr. Martin Luther King Jr. But this is one of my favorite quotes from Dr. King. Injustice anywhere is a threat to justice everywhere. We are caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly. And I think that network of mutuality, that will be relevant as we move through our presentation. Before we move any further, I'm going to tell you a very brief story, very short story. When I first graduated undergrad, I started working at this organization, and I very quickly learned that it did not align with my values. So I needed another job. So I applied to what has been traditionally known as outpatient mental health treatment, and that's what we called it at the time. I applied for one job, interviewed for another one, ended up being hired as an engagement specialist, which I thought was the best job. But mental health as a field was very new to me. So, with permission, I would ask if I could sit in on appointments. And I sat in on as many appointments as I could, again, with permission. And I remember I would sit in with one clinician, and at the end of the appointment, he would say, or he would start talking about my little angels. And I'll be honest, I wasn't sure exactly what he was talking about. So I didn't say anything, however, I just kept processing the visit. After sitting in on a few more visits with the same clinician, what I realized is he was referencing the participants. He was calling the participants in that program his little angels. And I remember, if I'm be honest, feeling uncomfortable. But I also felt, or actually believed, that there was something else. Like I believe there was something else about the situation, but I just couldn't put my finger on it. And then shortly after that, someone started talking about Sanism. Sanism consists of prejudicial attitudes towards people with mental illness, reinforcing negative stereotypes that demean people with mental illness or those who appear to have a mental illness. So I probably should have switched these bullet points, but I just really want to stress that someone doesn't have to have a mental health diagnosis to experience Sanism. For example, someone might be in the community and might try to patronize a business. And maybe based on their expression, that one makes a decision, and as a result, they're not able to patronize that business. And I really want to highlight that when we're talking about sanism or any ism, we're really talking about systemic oppression. So we're specifically talking about systemic oppression, discrimination of individuals living with a mental illness or that appear to possibly have a mental illness. And so to bring it back to my story, what I realized is that there were some that were viewing individuals living with a mental illness as inferior, childlike. That's where the My Little Angels came into the conversation, incompetent, violent, or dangerous. And again, to connect it to when we're talking about systems, we always say mental health care is healthcare, and healthcare is part of a system, and a system that we're all part of. And so it wasn't just about the labels. It was also, I realized that it became difficult when decisions needed to be made in regards to making a medication adjustment or possibly changing medications, that individuals did not believe that they were being heard in that space. And we want to just highlight that when we talk about sanism, it does exist on a continuum. And like many other things, it is always compounded when it's experienced by individuals who have been pushed to the margins. And just to give a clear example, because we talk about intersections often, but what does that really mean? So, just an example is when we're talking about involuntary in being admitted to the hospital involuntarily, what we know is that persons of color, and particularly Black individuals, are more likely to be admitted involuntarily. And then also, once they're there, they're more likely to experience restraint. And as we talk about the impacts of sanism, again, I really want us to think about, how does that happen on an individual level, but then also on a more macro level. And so, what we're seeing here in regard to employment myths, housing myths, I imagine that individuals on this call, they have heard this. You might have been with a participant and had this experience. But just in regards to language, many individuals with lived experience want us to be more clear and concise. Because oftentimes, I know for myself, my go to will talk about stigma. I want to say, oh, well, there's a lot of stigma around employment and housing, but there's stigma around people that wear eyeglasses. So if we specifically say sanism, then we know who we are talking about. And so things that, we've heard before, people living with psychosis cannot work. As someone experiencing bipolar disorder with psychosis said, I'd like to work. I've always worked. So it was a big part of my life and who I am. I couldn't imagine not working. Unfortunately, there are people that think individuals living with psychosis shouldn't be living in the community. I've had colleagues talk about, Crystal, I've been out with someone and we're looking for an apartment, and the landlord in our faces said, I don't rent to people that have a mental illness. And it's one of those, as we're doing this work, sometimes there are days where you're either going to laugh or cry. And he just said he had to stop. And he said, Sir, that is illegal. And so you probably should not tell us that. But in all seriousness, what we know is that stable, safe, and affordable housing supports recovery and helps prevent hospitalizations and involvement in the criminal system. If you talk to me longer than 5 minutes about first episode psychosis, you know that I believe employment and housing are mental health interventions. And my goal is always for us to keep people out of the hospital and out of the criminal system. Also, something that has come up lately is regarding one's faith and their faith beliefs and practices, and just thinking about how does Satanism impact like our response to one's faith and their religious practices. This is one of my favorite slides because it's just interesting that this was outreach. So we're always talking about outreach for coordinated specialty care. And it happened, I believe they were in New Mexico at a Native American charter school, and just going over the list that I know I have said numerous times, signs and symptoms of first episode psychosis or early psychosis. And someone raised their hand and said, well, you just described a medicine person in my culture. And so that's just one example of how us having to maybe stop and, we're thinking about the people that are on your caseloads. We know these are people that have a mental health diagnosis, and they also can have certain faith beliefs, practices. Many faiths will say that, I feel this Holy Spirit, or I hear the voice of God. And so we really just, even as someone is having a mental health experience, want to make sure that we're honoring their faith and their beliefs. And so you may wonder why I'm giving you a definition for disability from Americans with Disability Act. And one reason is because it is part of our objectives, but also many individuals with lived experience, they want to be able to own the label of disability. And they are essentially want to be able to determine how they are labeled. And so as I move through this presentation, I'm going to use person first language. I'm going to continue to say individuals living with psychosis, but we also do not want to always look at disability as if it's a bad word. So the ADA would say this is a legal definition, not necessarily a medical definition. A person who has a physical or mental impairment that substantially limits one or more major life activity. I also like this definition because if you look at our second bullet point, it also is in conversation what we just discussed in regards to Sanism. So having a mental health diagnosis or maybe the appearance of having a mental health diagnosis. So individuals do not have to have a disability, but could be regarded as having a disability. And so again, disability is not necessarily a bad word. And so according to the social model, it's very similar to looking at disability as the inability to participate fully in home and community life. And want to stress that this is not about there being a problem with the individual. Again, it's really looking at the physical and social environment and then looking at those barriers that makes it difficult for one to be able to fully participate in their community and their environment. So ultimately, the goal is to not fix the person, but the environment. And so really, that's one of the reasons we're here today is to provide some education, but we also know accommodations, universal design can be helpful. And universal design is not always talking about a hard surface. We're thinking about curriculum, we're thinking about our program design. But I really like this quote that reads, to eliminate disability is to eliminate the possibility of discovering alternative ways of being in the world, to foreclose the possibility, to recognize and value our interdependence. So again, it makes me think of earlier, Dr. King was talking about our mutuality. And so for, me, you, all of us to think about how we can support those alternative ways of being for individuals living with psychosis. Now, I want to acknowledge there are reasons that individuals might want to avoid labels. Psychosis continues to be considered one of the most highly stigmatized conditions. And so when we talk about internal stigma, that internal stigma doesn't come from just anywhere. You think about where it's Halloween season and Halloween can be fun, and I don't want to rain on anyone's Halloween parade. But we also know there can be a lot of negative images and messages around who has psychosis and what are some behaviors related to psychosis. And so, our goal is always we really want to minimize that duration of untreated psychosis, but some of those messages and as a result of internal stigma might be a reason that someone doesn't fully participate in care. And then also, we're just thinking about the individuals that we are trying to engage and then retain in coordinated specialty care. We're talking about adolescents and young adults and individuals seeking autonomy and, finding themselves and identifying who are they outside of the family unit. And for many of them, they just don't want the label. They want to just be able to show up as themselves. And we want to honor that as well. I always believe in action steps. And so there's always going to be something that we can do. So in regard to flattening the hierarchy, this is just old school cultural humility. And again, if you know me, I believe in culturally responsive practices, cultural humility, which cultural humility is moving beyond competence. It's about being curious. It's about that ongoing learning. And I'm really about just weaving that into the work that we do. So it's not seen as something extra, something else that we do. It just becomes part of the work. So, really looking at how we can explore inequity and discrimination in places that we already have to show up. So, we already have to show up for supervision, for consultation. So, if you notice something or someone brings something to your attention, having those conversations during supervision, consultation, your meetings with coordinated specialty care participants, allowing them to express themselves and maybe some of the experience they've had. Maybe they want try to find housing on their own, and they talk about experience that they had with a landlord. Because if I can be honest, when I talked about that experience I had with my little special angels, I was very new, and I'll be honest, I was very young at the time. But if I could have that conversation today, I would just ask the clinician, can we sit down for 5 minutes? Can we talk about what I observed? Can I tell you how some of the participants are feeling about some of your comments and your behaviors? Also, we want to think about mobility for individuals with lived experience. Do we have a career ladder pathway? And so whether we're talking about someone in a more conventional peer support role or some other role that someone with lived experience is participating in, are there options for them? And some people might be content being in that role, and that's fine. But are we providing options for individuals to move around or potentially to move up in the field? And also recreating environments where individuals can talk about some of their goals, and also creating environments and having conversations about, increased educational support, rather than someone wanting to complete a degree or some type of certification to be able to advance. Also, as we continue to talk about the design, again, design is not always talking about a physical structure. So again, as we're thinking about maybe creating a group within your program or thinking about adding some type of curriculum, we really want to think about how do we center the voices who are directly impacted, which greatly aligns with coordinated specialty care, but also before necessarily seeking a new design, look for what is already working at the community level. Because again, we want to be able to see individuals living with psychosis. We want to be able to see all the layers of the participants on your team. And so, what are some things that are already happening in the community? If there's a situation arising, typically there's somebody already doing the work. And again, that's a way to engage individuals, engage community partners, and really increase collaboration. And doing our own homework is also important. Joseph Fernandez is a peer advocate. They have been very open talking about their lived experience. Actually, Ajosa was almost a textbook case of first episode psychosis. They said they started experiencing symptoms when they were in college, and they did what they were told to do. They went to therapy, and they said initially there were no questions about necessarily what was going on, or what were some things that would be able to help them cope with their symptoms. They were being asked, well, what does it really mean to be Latinx, or are you sure you're non-binary? And they talk about the Sanism, how that contributed to them erasing other parts of themselves. All of a sudden, she wasn't reliable. She wasn't credible. She wasn't a credible historian to talk about these other identities that she also shares. And self evaluation and critique is part of that culture of humility as well. And I thought this was really interesting because it's easy for us to want to say or believe, well, I'm not Satanist. I don't hold these Satanist beliefs. But I was actually listening to a panel of individuals with lived experience. And someone with lived experience said, The question has to be, how do I unpack my own sanest beliefs? And he said this is a question he asked himself. Because again, he lives in this society, he lives in this world. And as we talked about earlier, we think about messaging and some of the things that people are observing or hearing, again, especially around this time of year, it becomes easy to internalize those messages. And so while again, we're thinking about more like system level approaches and action steps, that's important, but it's also important for us to consistently to get in the mirror and be able to do that self-evaluation. And just some very basic everyday actions that we can all participate in. Learn about the mental health experience. So, really learning beyond just the textbook, and that's important. But when I think about the JILSA, the expectation was not for the person on the other side of the desk to understand everything. What they were asking is for that person just to bear witness, for that person to, be curious and ask questions. We can also support the reclamation of pejorative language. There, within all groups, there unfortunately is language that has been used to harm, but many groups have taken that language back. They have reclaimed that language. And it's a way to create an environment and a way to empower themselves. Um, and so that language that was used for harm before is now, again, something that they're able to use in the sense of, again, empowering themselves and then others in their community. And then again, supporting those alternative methods of expression, thinking about individuals and as they're out in their community and, how are we providing safe and affirming environments so that they can, again, simply express themselves. So thank you for being here this afternoon as we talk about Sanism and what we can do to make sure we're providing safe and affirming care.